Welcome, everyone. We're so glad that you can be here today. I'm Christina Clayton. I'm one of the co-directors of the Northwest Mental Health Technology Transfer Center. Welcome to today's webinar, Opioid Overdose Prevention, with Allison Newman from the ADAI at University of Washington. Wanted to start with our land acknowledgement. We really want to acknowledge always in the University of Washington, we sit on the land that acknowledges, the Coast Salish peoples of this land, touching waters and tribes and bands within the Suquamish and Tulalip and Muckleshoot nations. This is still very important to us. We are in Region 10 for our center, and there are 272 federally recognized tribes. And we just want to be acknowledging of the land and the stewards from time millennial. And if you want to learn more about native land, that's in the chat, and it's pretty interesting, informative website. Just a few things we'll get over there, but you can see on the slide, obviously this webinar is being recorded. The slides will be made available, and the recording, we will have certificates, but not CEUs. Now a little bit about the MHTTC network, and folks can keep filling out the poll if they want. We'll share results in just a moment. So the MHTTC network is a nationwide network supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA. We have 10 regional centers, a network coordinating office, a National American Indian Alaska Native Center, and a National Hispanic and Latino Center. And there are similar structures and networks for the addiction field and prevention. So we support resource development, dissemination, training, and technical assistance, and workforce development for the mental health field. And we work primarily with the Region 10, but in this virtual world, we cover a whole lot more ground than that. Our Northwest MHTTC is one of our area of focus for the network is evidence-based practices for serious mental illness. Generally, we're talking about psychosis. So that includes CBT for psychosis and ACT. But we do trainings as we are today in a whole bunch of other topics, and we respond to formal needs assessment, conversations, input from you all. So we really do take care to listen to what you say when you do your evaluation, and if you have any topics or suggestions. We do this through a number of things. We do webinars like today. We have learning communities. We have newsletters, resources, a resource library on our website, and we have a podcast, and we have online courses. So a lot of things you can look into if you're interested later, and we'll give you those links. I think today is, it's always important that we talk about language, because within the network, we wanted to share this slide with every event to really talk about using affirming, respectful, and recovery-oriented language in all the work we're involved with. We know that, there are a lot of different perspectives that people may have. We're talking about very sensitive subjects sometimes today that might even be very personal. So we just ask that we communicate using respectful, non-judgmental, and inclusive language. And I think everyone's pretty clear on that. Some logistics, as mentioned, you're muted and off camera because it's a webinar. You can use closed captioning. We will share the video recording and slides and send instructions on how to get a certificate if you desire. For today, if you have something in the chat, as I've seen already, you need our staff's help. Gabrielle is back there making sure everything's running smoothly. Please throw that into the chat. If you have a question for Allison, that is where we're going to ask you put it in the Q&A box, and I will queue those up as we go along. If you have a real urgent question around something she's saying and you just don't think we can move on, please throw it in there, and I will certainly interject and make sure she can get to your question. All right. Lastly, your feedback is really important to our work. We actually look at all the aggregated responses. We don't have individual responses or can identify you. The survey changed. So if you haven't taken a survey with one of these events in the last couple of months, it will ask for a much longer personal code. I'll just say today, pick whatever numbers and letters feel good for you. We're not going to follow up with you. There's nothing, but feel free to fill that out however you like, because what we really want is your feedback. We will share that link near the end. We also want to share, this is a required survey for us. And of course, SAMHSA doesn't have official, opinions on our content, but we really look at your feedback and appreciate how to plan for future sessions. And it helps keep the free training coming, which is our whole point. So today's presenter, we're very excited because, as I said, it is International Overdose Awareness Day, and over 100,000 people died in 2021 from drug overdose. And today is really as Stop Overdose, it's overdoseday.com, forgive me, is the world's annual campaign to end overdose, to remember without stigma those who have died and acknowledge the grief of the family and friends left behind. And I'm guessing that some of you out there may be personally affected by this. So we're really grateful to have her. Since joining the Addictions, Drug and Alcohol Institute, or ADAI, at the University of Washington in 2017, Allison Newman has provided training and education on overdose, opioids, and worked on the website stopoverdose.org and learnaboutTreatment.org. She specializes in health education and healthcare access around drug use and health. And more importantly, I've gotten to know her through our department's equity team. And so very, very grateful that she was willing to come today, especially on this very important day, to talk. And so thankful that you're here to share resources and educate us on how to prevent overdose. So Allison, I am ready to turn it over to you, and I will stop sharing. I think that happened, and we'll let you get started. Thank you so much for being here today.
Yeah, thank you so much for having me. I really appreciate the chance to be here and talk about the work that I do and that I'm so proud of. Just also want to take a moment and just say this day is really important. I think we're reaching a point where many of the people on this call, and myself included, know someone who has died of overdose. It's something that affects, pretty much everyone at this point. So I do really appreciate those of you who are here today to learn more about this topic, because it's just really important, and unfortunately, it's becoming even more important as the overdose crisis worsens. So I'll start by just introducing myself a little bit. Thanks so much, Christina, for the introduction you did give. So I'm a health educator at the University of Washington Addictions, Drug and Alcohol Institute, and I provide Washington state-specific training and education on overdose prevention and response. I also do surveys and research with people who use drugs, mostly at Washington State Syringe Services programs. I'm focused on a public health approach to drug use. I'm not a doctor, nurse, CDP, social worker, etc. So some really specific questions I probably can't answer, but I can hopefully find the right person to connect you with. So what is a public health approach? It's really focused on reducing death or illness and improving quality of life at a population level. We use tools like epidemiology, health education, and policy to improve health. And also just hearing from communities about what's going on and what they think could work for them. So the way that a doctor or nurse or other provider might run tests, we do surveys and look at data to understand sort of what's going on at a population level. The other piece of this that I think is important is, in my goal as public health, our ultimate goal is to reduce death and improve quality of life rather than focusing on something like abstinence. So really, the ultimate goal is to keep more people alive, however that is going to work for them. So what I'm going to talk about today is just general trends in overdose nationally and in Washington State, new harm reduction approaches, the website stopoverdose.org that I work on, other resources that we have at our team, and some national and regional resources. So I'd love to hear from you. What do you hope to learn from this presentation? What are some questions you've had about overdose or what's going on that you want to make sure that I answer? And please enter those, I think probably in the chat, just enter what kind of things you hope to learn. See, prevention strategies. Do you mean primary prevention, which is like upstream, or tertiary prevention, which is like overdose response? I see that was a question for primary. Unfortunately, I won't be talking much about primary prevention. Most of the work I do is in tertiary prevention, which is really like, how do we keep people who have substance use disorder from dying from overdose, or people who may be likely to overdose. I would like to learn how I can create an opioid learning community of resources. That's a good question. Oh, risk factors, aftercare and support for family, friends, for loved ones. Are there warning signs? Oh, good. You're still looking forward to tertiary strategies. And I do have one sort of primary prevention resource that I'll talk about. So thanks for entering those. If you have other things you want to make sure that I cover or burning questions about what's going on, please just enter those in the chat. So I'm going to talk about, first of all, okay, in all honesty, no clue, we'll be listening to anything new and warning signs. Yeah, that's fine. Appreciate that honesty. And talk about trends mostly in Washington State, because that's where I work. And then looking at what state and local data can tell us about what's going on. So this is a summary of a press release from the CDC saying that more than 107,000 Americans died of drug overdoses in 2021, setting a staggering record. These numbers are really shocking. They just keep going up. It's becoming more widespread, and I'll talk a little bit about what's going on and why that's been happening. But I think, that's a very large number. It's the number, that's more than the number of people who are dying from car crashes or from gun violence. So this is a huge number, and it's affecting all sorts of different people in the United States. In Washington, we saw over 2,000 overdose deaths in 2021, which is a 68% increase since 2019. That we saw a higher increase in deaths among Black, Hispanic or Latinx, and American Indian Alaska Native people. The majority were male, and the average age was 45. Over half of the overdose deaths involved fentanyl, and almost half involved methamphetamine. Let's see, accurate info versus overdose myths. Like, can someone really OD by touching or breathing in fentanyl, for example? Maddie, I will definitely discuss that. Thank you for bringing that up. So this is just a show in Washington State where we're seeing similar trends, this rapid escalation of an already bad situation. Nationally, we've also seen increases in overdose deaths among these populations in Washington as well. I think what is a little bit different about Washington is how many deaths involve methamphetamine. That's something that tends to be more of a West Coast phenomenon, but is also spreading to other areas, including, I think Ohio is also seeing a big increase in methamphetamine involved deaths, other areas of the Midwest and East Coast. So I have access to more granular data in Washington State. This is a web page we have through ADAI that my colleague Jason Williams works on. He receives preliminary death data from the Washington Department of Health and then puts it on our webpage so we can better understand what's happening. I'll say that the data starting for Q4 and Q1, so 2022 and Q4 of 2021 are preliminary. So those numbers are likely to increase. The big thing to look at with this is we've seen heroin deaths continue to decline. We've seen, cocaine deaths are low but fairly flat, but deaths from psychostimulants with abuse potential, which is really methamphetamine, and deaths that involve fentanyl are just rising really, really dramatically. And that they're really driving that increase in overdose deaths. Let's see. Oh, can anyone carry naloxone? I will definitely answer that. So this is the same data presented slightly differently. It's the percent of deaths that involve these substances. And as you can see, we saw deaths that involve commonly prescribed opioids have really dropped. It was about 30% of overdose deaths. Now it is like 10% of overdose deaths in Washington State. Heroin deaths are even lower. And that fentanyl and methamphetamine are making up a larger and larger percentage of deaths. I point this out because it's really important that we adapt our overdose strategies and our primary prevention strategies to the current state of things for overdose. Strategies that are just focused on prescription opioids are unlikely to have much of an impact, given that they're not really driving overdose deaths. A lot of those were really effective interventions, but now that's just not what's going on. I see a question. Are most of them, these meth-related ODs, due to combining meth or opiates or just meth? That is a great question. Of the deaths that involve methamphetamine, about half involve an opioid and half are meth only, or meth with a different kind of drug. The meth only deaths tend to look like stroke, seizure, or heart attack. And the meth plus opioids deaths tend to look more like an opioid overdose death, where someone's breathing has slowed or stopped and they can't wake up. So it's split about 50-50. So we do see people dying from meth only, contrary to sort of the belief that you can't just die from meth. The data says something really different.
Allison, sorry, I don't mean to
Yeah, that's
interject,
fine.
but I know we
Go
were
ahead.
speaking about this before. Is there more attention or just more keen attention to what is considered a methamphetamine overdose? Given that you talked about the misunderstandings or misconceptions, is it just now we're actually paying attention like, oh, this actually was, and they, died in this way, looks different than an opioid overdose, but we actually now can call this actually attributed by methamphetamine?
I don't think the increase is just due to like a difference in reporting.
Mm.
I think it's something that has been happening for a while.
Mm-hmm.
The issue may be that it's harder to treat stimulant use disorder. We don't have easy tools like naloxone, which reverses an opioid overdose. We don't have something similar for methamphetamine. And in my experience from talking to people who use drugs, many of them don't perceive that you can die from methamphetamine alone. So there is this idea that you can't, even though some of the people I talked to are like, oh yeah, I saw someone like have a seizure and die from using too much meth, but you can't really die from meth by itself. So
Right.
I can't completely unpack why that is because I don't necessarily know, but I think there's less attention to methamphetamine for all sorts of different reasons. It has been this longstanding narrative that it is an opioid epidemic, but really for the whole time, it's been an overdose epidemic. Most of those deaths all along have been polysubstance. So, what's the difference again in deaths? Chelsea, could you clarify what you're asking? Are you wanting to know which deaths, about half were of deaths that involve methamphetamine, half were meth only and half were meth plus to opioid? I think maybe that answers your question. Oh, what do they look like? So an opioid overdose death, someone's breathing slows or stops and they can't be woken up. Basically, their brain is so relaxed it's not remembering to breathe and their heart will stop beating. What happens with the methamphetamine involved death is the opposite. Someone's heart, may be beating way too fast. It can look like stroke or seizure or heart attack. So complete opposite. I see the question about how many people think they're only using meth and that it's cut with fentanyl. I would say that's very rare. What we've seen from crime lab data is most of the methamphetamine in Washington state is methamphetamine. It does not seem to have fentanyl in it. And when we talk to people who use drugs, many of them are using methamphetamine and opioids, which I'll get a little bit into. So I'll dive forward in the data and not. Hopefully this will answer some more questions. So fentanyl in Washington state, we've seen a huge increase in overdose deaths. Most of this is due to fentanyl, and we've seen this nationally as well. The risk from fentanyl is due to its potency and the unpredictable amount in the illicit drug supply. So in Washington state, we've mostly seen fentanyl in these fake M30 pills. One can have almost no fentanyl, one can have a deadly amount. It's hard to know. There's no way to tell. There's no way to know if fentanyl is in something just by looking at it. On the East Coast, fentanyl showed up much earlier, and it was mostly in powdered heroin. In Washington and a lot of the West Coast, we tended to have more black tar heroin, didn't really have fentanyl in it. East Coast, fentanyl was showing up in powdered heroin a few years earlier. So East Coast saw a big increase in overdose deaths earlier than the West Coast, but now we're starting to catch up, unfortunately. What we have seen is it's affecting a broader population, including younger people, more Black and American Indian, Alaska Native people, and in some states, more of the Latino or Latinx population is affected. So this is Washington state specific data. But what we've seen is that overdose deaths that involve fentanyl, the rates are close to the same for people over 30 and under 30. This is really concerning. There's very few causes of death where you would see a similar death rate for people over and under 30. This is really showing there's a big escalation in overdose deaths in younger people. And the other thing to point out is we're seeing many, many fewer deaths that involve prescription opioids, especially among younger people. We're seeing that fentanyl use and overdose deaths appear to mostly affect young adults who are inexperienced with opioid use, young adults with rapid onset opioid use disorder. So we think fentanyl may lead to use disorder more quickly, and then adults with ongoing opioid use disorder. So people who've had opioid use disorder for a while are now using fentanyl because it's what's available. So methamphetamine, it's involved in about 40 to 50% of overdose deaths in Washington state. It's not always highlighted in the conversation about overdose and the epidemic. And as I said, about half of the deaths involve opioids, half don't. And there's no overdose reversal medication, no FDA approved medication, but there's some effective behavioral treatments. And people who have methamphetamine use disorder do recover. I know people who've recovered. So it's not hopeless. It can just be a little more challenging. So what's happening in harm reduction? We're going to talk about safer smoking and drug checking. So what we've seen in Washington state is as fentanyl has become more widely available and as it's been in mostly pills, we've seen there's a shift to more people who are smoking drugs, including fentanyl and methamphetamine. And we're starting to have a conversation in Washington state about including safer smoking supplies at harm reduction programs like syringe services programs. So places that just do syringe services are saying we have people who are smoking, they'd like access to safer smoking supplies, and some programs have already started to do that. We think it's important to start to have this conversation. So because these harm reduction programs are such an important entry point for people to access things like HIV testing, hepatitis C testing, referrals to treatment, referrals to housing. So harm reduction programs and syringe services programs are such an entry point for people into this larger network of services. The other thing is that safer smoking supplies can help people inject less frequently. We know that sharing injection equipment is a risk for HIV and hepatitis C transmission, and that if we encourage safer smoking, people may be less likely to acquire those infections. So that's just one thing that's going on. We do have this brief that some of my colleagues wrote about distribution of safer drug smoking supplies. So the other thing that we're starting to see is more drug checking. So one is fentanyl test strips. We're starting to see more community distribution. These are a test strip that was originally developed for urine drug testing, but is now being used to test pills or powders. They have poor sensitivity and specificity, which means that they have a lot of false positives. They don't actually tend to have that many false negatives, so I should probably delete one of those. They don't have a lot of false negatives, but they tend to have a lot of false positives. There's also a legal gray area in many states due to paraphernalia laws, which often include fentanyl test strips. So it's not always clear whether it's legal to distribute them. Oh, I have a good question, Melinda. Never heard of safer smoking, so what are those tools? Those can include things like foils or glass pipes that people can use to smoke heroin or methamphetamine. The benefit of that is, you know, they are less likely to inject. They're more likely to come in. I wish I had put in a picture of what those can look like. We did a panel a few months ago where we had people from 2 Washington harm reduction programs talk about those. And I will try and find that link and send it to Christina to add, because we had panelists talk about what they're giving out. So, but yeah, it's like glass pipes, foils, things along those lines. And people can come in and get those supplies. They can also distribute them to other people. It helps them inject less frequently, and it also helps them, you know, be using their own equipment and not sharing. Especially during COVID, we think it was important that people are not sharing smoking supplies. So fentanyl test strips, becoming more widely available. There's still challenges. They can be sort of expensive. They're $1 a piece, which if someone has, opioid use disorder and is using fentanyl, they would be going through a lot of them every day if they wanted to check it every time. So fentanyl test strips, a tool, very imperfect tool. The other thing that we're looking at in Washington State are drug checking machines. It's a FTIR, which I cannot remember what that acronym stands for, but ADAI is going to be doing a pilot where we'll be working with harm reduction programs and setting these machines up at harm reduction programs. People will bring in their drug, scrape a small amount of it onto this machine, which will give them a readout of what is actually in their drugs. A huge issue right now with the drug supply is people just don't know what's in it. There's fentanyl in a lot of drugs. And now we're starting to hear things about xylazine, which is a veterinary tranquilizer that's showing up in some parts of the state and the country. So there's a lot of stuff in the illegal drug supply. If people know what's in it, they can make more informed choices about when and how to use if they're going to use that drug. So it will also help us in health education to be able to say, here's what we're seeing is in the drug supply. Here's steps you should take to stay healthy. So those are two different things going on right now in harm reduction that are sort of new and evolving. So yeah, fentanyl test strips aren't legal in all states, Idaho, for example. They are not technically legal in Washington State, but no one is being penalized for distributing them. So thanks, Adam. I'm going to read your comment. I love this. Addiction is a tough case to crack, but it's relatively easier and more practical to reduce harm as a first step. Yeah, thank you for that. I know some of these things may be new topics for people, but really the goal is to help people be as healthy as they can at that given day. We know that substance use disorder is an ongoing chronic condition. It can be hard for people to recover. People do recover, but we want them to be as healthy as they can wherever they are in that journey. So thanks for all these questions. If there was anything I didn't answer, please just put it in the chat. Yeah, xylazine is the same as tranq, and I'm just learning about this, so I can't really answer any questions yet because it is a new topic for me, but I can answer yes, Maddie. So I'm going to walk you through a few of the resources we have on stopoverdoseorg. A lot of these are Washington specific, but we've had people reach out and they have adapted them for their own organization. So I work on stopoverdoseorg. It's a website run by my institute, and we now have a new name for our team, the Center for Community Engaged Drug Education, Epidemiology, and Research. Our website is funded by the Washington State Healthcare Authority, and the goals are to communicate with the public about overdose, provide resources for professionals, and translate research and policy into community action. So our most visited page is our Find Naloxone Near You page, which if you're in Washington State, you can go to this page, find out community organizations where you can pick up naloxone. We have a new mail order program through Washington State where you just click on a link, fill out some information, and you can have naloxone mailed to you. So this is our #1 most visited page, and I'm pretty proud of how much people use it, and that we are continuing to add resources throughout the state. The other page that is very visited and I want to make sure people know about is we have an Opioid Overdose Education page. It includes brochures, which I think we now have in 16 languages, thanks to a partnership with Public Health Seattle and King County. They translated our brochure, so we now have it available in a lot of languages, including things like Quiche and Amharic. We have our opioid overdose video, which is available in English and also dubbed into Spanish with Spanish subtitles. And this is downloadable. It's nice to have a video so that we can ensure that people are getting consistent information. I also learned recently that the #1 place people get health information is through YouTube. So I think videos are a really great way to get the word out about things. We've added a lot of new content recently, including this page about fentanyl, which if there are any things I didn't answer, definitely go check out this page and you can learn a little bit more about fentanyl. I saw the question about whether or not you can overdose from touching fentanyl, and you can't. So this is something Christina and I talked about. There has been a lot of misinformation out there about whether or not it is safe to respond to a fentanyl overdose. And I can say from the reading I've done, from talking to people, we know it is safe to respond, even if you think someone has overdosed on fentanyl. There's little to no risk of overdosing from touching fentanyl. There's a position statement on this webpage from the American College of Medical Toxicologists, and you would have to have your hand in fentanyl powder for hours for enough of it to absorb through your skin for you to even feel the effects. So it's safe to respond to a fentanyl overdose. We want people to feel comfortable responding to a fentanyl overdose, and we have information about that on this page. So these pages we're updating all the time. We add new content as new topics emerge. Unfortunately, the epidemic keeps evolving and we have to keep adding new pages. I think we'll be adding one about the illicit drug supply and some of the things about drug checking sometime soon. So I hope that answers your questions about fentanyl. We also have a page about stimulant overdose. This is we made a short and a long brochure. This is the short one. I was told, make it really colorful. That's what the people who use meth told me, said, make it really colorful so that people want to look at it. And we broke it down really into the symptoms to look for, and that someone needs to call 911 or get medical help right away if they see any of these symptoms. This is also available in Spanish. This has been a pretty popular brochure as well, because there just aren't that many resources out there. We're working on a similar type handout just around fentanyl, which should be available sometime next month. Similar kind of process where we talk to people, community about what they were hearing and sort of common misconceptions. So we've also added a page specifically around youth overdose education. A lot of our content originally was focused on people who use drugs and sort of older people who use drugs, very sort of classic harm reduction. But there's been a real need for how we talk to young people about this. So trying to put together resources that are really focused on talking to young people about overdose, tips for how to do that, and what resources sort of exist already about how to do that. I think one challenge I've seen is a lot of the youth education is explicitly primary prevention. And I think that's so important. I've actually worked in primary prevention, but it's been very difficult to get any overdose education into that because of some of the philosophical things around primary prevention. And we want to make sure that any young person who's at risk of seeing an overdose is ready to respond. So I've been fortunate to work with King County and Rescue Agency on this campaign called Laced and Lethal, which talks to young people about the risks of fentanyl. And what they found is that most young people thought other people are at higher risk for fentanyl overdose, but that they really wanted to help their friends and that they were open to carrying naloxone and learning about overdose. So try and incorporate some of that info onto this page. Make sure it's accessible, and make sure that young people have the resources that they need to be able to reduce their own risk for overdose or to help a friend who's in need. We have a whole bunch of pages for professionals, and each of these emerged basically from like different conversations. So we have a page for libraries because my colleague Meg Brunner and I did a series for libraries about overdose response. Unfortunately, all these different places are seeing more overdoses. We have a schools page because Washington now requires that schools have at least 2 doses of naloxone on site in case of an overdose. And schools, we wanted them to have the information they needed around this and in a place that was easy to find. So kind of similar, each professional sort of category has different needs around what they need to know around overdose, what laws are relevant. So we have pages for each of these. Washington now also has a law, SB 5195, that requires all behavioral health agencies to be able to prescribe naloxone and try and use patients' insurance to reimburse for that naloxone. So put together resources around that for this webpage. So kind of other relevant resources that I just want to make sure that you're aware of. Actually, I'll stop. Are there any questions about anything about Stop Overdose? Was there anything I didn't cover so far that were outstanding questions? All right, I'll continue then. So another big part of my work and that I love doing are these community surveys with people who use drugs. And this started before I started ADI. We have been surveying participants at syringe services programs since 2015. That survey is done like on paper and then entered, into software. Done it 2015 and then 2017, 2019, and then most recently in 2021. And these surveys really give us unique perspective about what's happening with people at syringe services programs, helps us understand drug use patterns, how people are using, and also what services people would want. And I've also been really fortunate to get to do qualitative interviews in these settings. And let's see, 2018, last year in 2021. And then currently I'm working to get interviews up and going where we're going to interview people at syringe services programs about fentanyl use and what services they would want around that. It's an area where we just don't have as much information as we'd like. And doing these kind of surveys will help us understand that. So the 2021 qualitative interviews I did, I was fortunate to work with a grad student who was just wonderful. We talked to 27 people, mostly in Eastern Washington, about what they'd want around methamphetamine use. Really great interviews, usually about, I'd say 15 to 40 minutes, really depending on the person. Asked them about why they were using methamphetamine, what they thought about services, what their experiences were with different services, and really how to try and help them. So the key points we got from that were that most participants saw both benefit and harm from their methamphetamine use, that about 2/3 were interested in stopping or reducing their methamphetamine use, and some were just interested in cutting back. We had I think it was one person who's like, nope, I just really like using meth and I'm going to continue using meth. But even that person was really interested in some of the services we were talking about. So to me, the key point with that is wanting to cut back or reduce isn't the only time you should be offering someone services. You should really be seeing what they need at any point, and not just wait for them to reach out based on interest in treatment. A big takeaway was that many of the people we talked to lacked stable housing, employment, or other practical needs like transportation, childcare, and primary health care. So a lot of people talked about how their methamphetamine use was really tied in with these lack of these social determinants of health. So, people were using because they were unhoused and they needed to stay awake through the night because they didn't feel safe where they were sleeping, or they were using because they didn't feel good about their current life situation, and methamphetamine helped them feel better, at least temporarily. Other thing was that their interest in reducing or stopping was not static even throughout the interview, and that there was really, sounds funny, strong ambivalence around methamphetamine use, where people could see the positives and the negatives, were very self-reflective, had a pretty good understanding of their situation, but weren't necessarily sure how to change things. And that a lot of people had already taken steps to cut back, which was interesting. So if this is a topic you are interested in, we do have a full report. We did a webinar, we did a Prezi, so you can check this out. A lot of this work on these surveys and qualitative interviews feeds back into how we do things on the webpage. I think it's really important that we're talking to people who are using these substances, so we can think about how to present that information in a way that's accessible to them and that reflects those viewpoints in the information that we put out. So the other website I work on, which it looked like we had a lot of behavioral health people, is this website, Learn About Treatment. We wanted it to be a companion to Stop Overdose, but more focused on treatment for opioid use disorder and stimulant use disorder. This website includes resources on the medications for opioid use disorder. We have a friends and family page and a page for healthcare providers. I think a resource that would be of huge interest to this group is we have a whole bunch of training videos from our Washington State Opioid Response Training Team. And these include a lot of resources on like co-occurring mental health and medications for opioid use disorder, you know, how to talk to your clinic. So we have really great list of training videos. Another resource I probably should have called out more specifically is we created a brochure that explains the 3 FDA approved medications for opioid use disorder. The SAMHSA booklet that does the same thing is 64 pages long, which is great, but we felt like people weren't that likely to read that. So we made like a 1-page, you know, quad fold brochure that explains the 3 medications, the different settings where they're available, and how those medications worked. This website is learnabouttreatment.org. But this medications for opioid use disorder brochure is available in English and in Spanish. It's been very popular. It's not the same as, you know, an in-depth conversation, but hopefully it can give someone a little bit of an idea of sort of how those medications work and what might be a good fit for them. So really the goal with all of this is to provide people with the information they need to make a healthy choice for themselves, or at least start to be informed about what good options might be. So I know that there are people here from states like Mississippi. I don't have any Mississippi resources, but I was able to pull together some different regional resources for Region 10. So why are regional resources important? States have different naloxone and Good Samaritan laws. It's really simple as that. I know that every state in the country, you can now obtain naloxone from a pharmacy, but the nuances of those laws are different. Same with Good Samaritan laws. I think Washington was one of the first states to have a Good Samaritan law. This is the law that if someone responds to an overdose, both the person who's overdosed and the person calling 911 are protected from prosecution. In Washington state, that's protected from prosecution for minor possession. It doesn't cover outstanding warrants or felonies. Other states, we're one of the first to have a Good Samaritan law. So interestingly, ours is written more narrowly. Other states that went after tend to have a broader law. So the nuances of these laws really differ from state to state. And it's important to know what is allowable in your state and sort of what the rules are. Unfortunately, we don't have something that is, you know, totally nationally consistent. The other thing is specific communities may have different needs or require different messaging. So what works in Washington may be really different than what works in a smaller state like Rhode Island or a state like Florida. Other states may want to have their website available in different languages. Recently, we were able to get a Google Translate plugin for Stop Overdose. It's now available in 20 different languages. I can't say whether the translation is any good or not, but we wanted to make sure that, you know, lots of people could access it. So that's why regional resources are important. We want people to be able to have access to the local information that they need. So I learned a little bit by putting together this project. If you're in Alaska, there's Project Hope, which is a resource for where you can get a Narcan kit. Narcan is a specific formulation of the drug naloxone. That's why it has a trademark. But it's great. Here's a map of where you can get naloxone in Alaska. It's Project Hope. I thought this was pretty cool. In Idaho, they have a really great website about opioid overdose and naloxone. Really love their video. So very easy to follow and use. They also have a dashboard, which I am very envious of. I will say in Washington state, it can be a little hard for me to find up-to-date data, but I think Idaho's drug overdose data dashboard does a really nice job of presenting what's happening. It's really important that people are able to access this and get this kind of local data. And then Oregon, I got all sorts of good ideas from Oregon's website, which is Reverse Overdose Oregon. really easy to use, really easy to find the good information, find naloxone. So if you're in any of these Region 10 states, these are great resources. A tribal specific resource that I use a lot is the Northwest Portland Area Indian Health Board website. They have really great resources around opioids and overdose, and they actually have a harm reduction echo for tribal providers, which I am not a tribal provider, but I attend anyway because I often learn something. So really can't say enough nice things about their resources and their technical assistance. Really wonderful, wonderful resource for tribes and urban Indian organizations. So a resource I use a lot that is national is the Harm Reduction Coalition. They have really wonderful handouts. They're very up to date, have a lot of good information, very community driven. Been using their website basically my whole professional career. Really wonderful, wonderful information. Next Distro is another website I use a lot. You can order harm reduction supplies from them. They also have really good handouts. They have a handout on xylazine, also known as tranq. So if you're wondering sort of what information is out there, they are really current. They have really great info about what's going on. And you can order different harm reduction supplies, including fentanyl test strips. National resource is the CDC, who interestingly named their website Stop Overdose. My boss was joking, that they stole it from us. It's fine. I think it's really good for them to name it that. But they do have some really nice resources. I think they're starting to catch up, though they do have a really weird thing where they have all the slang terms for fentanyl, which I think those get out of date really fast. But they are starting to really add nice content on fentanyl, polysubstance use, naloxone, and stigma reduction. So that's all I have. This is my email if people have questions. And I'm also happy to take any questions that we have that I didn't make in the chat, or if people have any other questions they want to add in the chat or the Q&A.
Wow, thank you, Allison. You went through a lot of information, and I did see, I really can't believe you got through it early. I think that just the sheer volume of people commenting, can I get the slides? How do I learn more? I want to be able to share this. Just can't thank you enough for being here today. There was another resource I was familiar with. So I was thinking, I was actually on that Harm Reduction Coalition website when you mentioned it, because I'm also familiar with them. There's the Native and Strong here in Washington. It's a Washington Tribal Opioid Solutions. It's got some really good resources as well. I do want to make sure that people have, more time for questions, but is there something that you didn't cover today that you left out because we weren't sure there wasn't enough time, given who's in the audience? I guess I'd be curious. We don't have any polls, ready to go, but I think, does everyone here at least now know, what we talked about before? Anyone can get naloxone to keep on hand for themselves in case an emergency within their family, in the community, that's easily done, at least in Washington. What are other common themes? I know we talked about this earlier. What are some of the, you talked about you can't overdose from fentanyl, from helping someone who's overdosing from fentanyl. Other things that come up a lot when you do these trainings would be good to maybe think about.
I think knowing that I think nationally anyone can have naloxone in case of an overdose is really important, and you can find your state resources for that. Also, something that comes up a lot is the expiration date for naloxone. Although it says, 2 years or 3 years out, likely it's effective for up to 10 years. If you're in an organization that has naloxone on site, it's always good to get a new kit when that one expires. But if you're just someone who keeps naloxone on you, keep it past that expiration date. It's likely to be effective for a very, very long time. So you don't want to throw out a kit just because it's expired. It's likely to still work. So I think that comes up a lot, and it's really important given that naloxone is still sort of expensive, especially for organizations. So don't throw out a kit. If you are an organization that has it and you have expired kits, it may be that there's a syringe services program or other harm reduction organization that can hand that out. Other things that come up, I think one thing that's really challenging is that harm reduction programs operate in how would we properly dispose of an expired kit? You can put it in a medication disposal bin, or you can give it to a syringe services program that could then hand it to an individual. It's likely to be good for like 10 years past the expiration date, if not even longer. So going back, I think the big challenge in just awareness is that a lot of harm reduction programs, syringe services programs, operate in a really challenging political space. There's a lot of misconceptions around what these programs do. There's a lot of stigma around people who use drugs. These are really important and evidence-based public health programs. They prevent HIV. They help prevent transmission of hepatitis C. They help keep people alive, and they're often, the only space people are in where they don't feel judged. So supporting these programs is really important across the whole spectrum of treating substance use disorder and preventing substance use disorder. They help keep people alive. They're really, really important, and they are underfunded and don't always get as much support as we might hope.
I think that's an interesting point. And I know, as we talked earlier, harm reduction can get very misunderstood. A lot of, political things, moral things around that. We know there are a lot of racial and ethnic disparities. You talked a little bit about that before. I think just thinking about, if people who are in the audience today listening to what you're saying could take a couple of key nuggets, they are not going to rattle off all the stats. That's not their job, probably. Thank goodness you're here. So we can't possibly digest that and have that at the ready. But what are a few things that anyone could try to do? And even if it's challenging our own assumptions, it's challenging our own feelings, it's challenging perhaps our own personal experience or familial experience, or just having that judgment because I see stuff on the street and I feel a certain way about that. What are things that any of us could take away and potentially try to do a little bit more to help those that are in these really risky situations that generally, in my experience in the field, are sort of the last, no one is interested in, and then there's like this really strong group that feels passionate about, like, this is not, these people cannot be thrown away, like these are not people to ignore, like we have to help everyone in our communities.
Yeah, I'd say simple thing is to speak up for harm reduction organizations. I think we did a little bit on the podcast today, but harm reduction is something all of us do every day. Seatbelts are harm reduction, designated drivers are harm reduction. We're all practicing harm reduction. It gets more complicated with substance use because some types of substance use are illegal, which adds a whole other layer to things. So speaking up for harm reduction organizations, and then if you are a behavioral health provider, connecting people with harm reduction resources in your area, being aware of what those resources are, so that if someone does have a recurrence of use, they're able to stay healthy and stay alive, stay okay, even if they are using substances. So if you're not already familiar with the resources in your area, learning a little bit more about them, connecting with them, and even going to visit one if you haven't before. I used to work in a syringe services program out of a van, and the people were wonderful. They were so appreciative of the services. There was a lot of self-stigma. One guy, I trained him on how to do naloxone. I was like, yeah, now you can save a life. And he's like, oh yeah, I'm such a effing Boy Scout. And I'm like, no, like you really are. Like you now have a tool to help save another person's life. You've done a lot of good. So reinforcing the positive things people are already doing so that they do know, they're valuable members of our community.
Well, and probably going to get on my soapbox a little bit, but I've been in the field my whole life. So I do feel like it is so understandable that people don't want to see disarray and the harmful effects in our society that all these things come to. And, no one's claiming that we've got a perfect society and that we're treating everyone equally and everyone has a fair chance and all of that. So we're not going to debate that here. So it's easy to sort of look and see from the outside and go, oh, I don't like that. I don't know what that's about. I don't know why anyone would do that. And it's that suspending judgment, right? It's that I don't possibly have any clue what brought this person to where they are, what I'm observing today. And I can possibly guess it was not all just a deliberate, this is exactly where I wanted to be, and this is how I enjoy life. And the stigma that you mentioned, I think, is so powerful. And I think as we work with folks, whether it's mental health, substance, homeless, like all the different things, there's stigma about having, I'm sure different medical conditions, but I think that the shame, and it really becomes deadly when people don't feel they're worth saving, they're worth living. And so I guess as we have our feelings, we're going to have our automatic reactions. I just think that when we are working with people and we're thinking in these larger senses, this is probably not anyone's dream situation, and it didn't start overnight, and it's not going to be fixed overnight. So because all of us have had a change that we needed to make. And that's the other thing that I wanted to sort of share, because I think you do that exercise, like, well, how long have you known you needed to do this thing to change something? And how old are you now? And it's always years. And we probably have had housing this whole time, and we've had family, or we've had friends and finances. And so anyway, I know I was going to get on my soapbox, but it's it's a passion for me as well. And I understand the struggle, because you hate to watch people suffer. You hate to see people maybe, choose things you wouldn't choose for them, but that's not our position, right? We're trying to keep them alive and trying to make them, perhaps the next time, they'll know there are other options there. It's not that they're forgotten, especially on today. So.
Yeah, I think that's a great point. I think this was such a spectrum of people who are on this. I know we had primary prevention people as well, and that's so great that you're here. Also, if you're working with someone who is using substances, make sure to talk to them about fentanyl. I think that's a huge thing, making sure they know it's out there, that it is a higher risk for overdose, and that there's steps they can take to reduce that risk. I'd say that's the number one practical thing. The number one sort of more touchy-feely thing is just to listen to people, and then really reinforce the good things they're already doing, because a lot of people who use drugs don't hear that enough. So reinforce the good things that they're already doing.
Yeah. Yeah.
Oh, I do have a question about Suboxone.
Yeah, please. And I do realize I get very excited with all the links. So we will make sure we have this stuff. We will capture all this and put it on our product page that has the recording. It'll have the slides and all of that. So please feel free to answer that last question, as I know we round out our time.
Yeah, I will try and answer it quickly. So Suboxone is also known as buprenorphine. It's one of the 3 FDA-approved medications for opioid use disorder. Methadone and buprenorphine both reduce someone's risk of dying from overdose by 50%. Methadone is only in specific treatment settings. Suboxone, aka buprenorphine, can be prescribed by any medical provider and taken home as people do other medications. And they really do help people achieve stability, get them out of that sort of cycle of use and withdrawal, and can help them deal with the other aspects of what's going on in their life. And if you want to learn more about that, we do have more resources on Learn About Treatment. And there's other good resources online. SAMHSA has some good info as well.
And I just want to tie that together, because I think that is probably a misconception as well. People have, maybe not here in our audience, but about, needle exchange or other kind of syringe exchange situations. Like, well, we're just, letting them, whatever Yahoo kind of stuff you might say, but people don't maybe acknowledge, like, your relationship that you're describing with people over time. What's going to help any of us do better and feel better is having someone that believes in us and trusts us and that we trust. And it's not about that minute to minute. Suddenly their whole life is going to switch to a different looking thing.
Mhm.
So it's having that care over time. I just want to thank you, Allison. We could definitely talk all day. And it's so nice to talk to you about these kinds of things. I do want to just share and say thank you to everybody for being here today, and, just honoring if you've lost someone, and just thinking of that today. And very, very grateful that you're here today. Obviously, people really wanted and needed to hear the information. So thank you so much.
Yeah, thanks for having me, and thanks for everyone who asked questions and came today. Really appreciate all of you.
Yeah. We'll leave the room open. A big shout out to Gabrielle out there trying to get everything and keep everything organized. We are going to, hold on, let me get to the right thing. Here we go. We do have a couple of upcoming events, and just wanted to share that real quick. Your feedback is important. If you can please do the Gipper. I don't even know if the Gipper got in the chat because we were so riveted by the information. But we will get that to you and email that to you. And I think I just screwed up the screen here. So anyway, we'll just stop because I don't know where I'm sharing now. My mouse has been not cooperating, but we will send you some things. We'll send you the link. And we do have some great for Recovery Month, which starts tomorrow. So National Recovery Month, we have some great events from NAMI Seattle and others on the horizon. So thanks again, Allison. We'll leave the room open so people can grab links or whatever, but we'll capture most of this and put it on our page as well. Thank you so much.
Yeah, thanks so much.
Okay, take care, everybody.
Bye.
Bye.